or iron deficiency anemia. That's what it's called. Now, I want you to look at the story behind this young woman. 23-year-old woman, history with small bowel resection because of Crohn's disease. She is fatigued, she has dyspnea, all right? She is pale, and she has an unsteady gait. In other words, when she walks, she doesn't walk confidently. Okay? She's kind of, right? Not wobbly, but she has a very tentative kind of thing. She's, okay? Remember, she's 23 years old. She's not 73 years old. All right? Lab results revealed a hemoglobin of 10 with a mean corpuscular volume of 120. Remember that calculation I just did? Remember the calculation? That number we got, 78? So that calculation for this patient is 100 mil. Now if you remember the previous slide, the normal was 80 to 92 or something. Okay. How could we explain this presentation? And then the smear, the blood smear is shown. All right, the blood smear is shown. Now, look. So you got a neutrophil, and it looks normal. Am I right? Yes? Who said yes? It is hypersegmented. It should have only 3 to 5 lobes. This one has, I don't know, 6 and a little bit kind of thing. It's hypersegmented. You look at the red blood cells, they all don't seem to have the same size. I have oval-shaped ones, like this one, okay, like this one, all right? I have some that kind of look like normal, that one, maybe that one, but they look bigger than normal. I have bite-side cells, B-I-T-E, bite cells. This one here, it's a bite cell. It's a red blood cell where a macrophage has taken a chunk out of it because some of the proteins underneath it were damaged. Inside the cell it was damaged, so the macrophage came and took a bite of it. So it's called a bite cell. Okay? So, can we explain this patient's presentation? Let's see if we can. We want to talk about 2 B vitamins. The one is called folate. You might also know it as folic acid. It's the same thing. And vitamin B12. You might also know it by its fancy name called cyanocobalamin. Just call it B12. Right? Again, B12 and folate are required for DNA replication. Now you've done replication a couple of days ago, am I right? Yes? And I'll do a quick review for you in a minute or two. Required for DNA replication. And generally, this is in cells that are rapidly dividing. Which cells are these? Skin cells. Enterocytes. Okay? Or hematopoietic tissue. Red blood cell production, white blood cell production. You require a lot and a lot of DNA replication because you're going through cell divisions. Now, that means the cells must be replaced pretty frequently in these tissues, and if it's not replaced, then obviously, you're going to have damage. Now, I want you to listen to me for a minute. Just look at me, don't worry about the slide. If you remember hematopoiesis, you've got a stem cell, yes? You then got precursors, they divide, then you've got another division, and another division, and another division. Yes? You follow? Now you're going through a series of divisions. And every time you divide into 2, you need to carry out replication. The other thing that's happening is, by the time you come down to either 10th division, you say, the cell has become, like the red blood cell has become, tiny. Yes? There's a question for you. What if the division stopped? So it's supposed to be 10, it stopped at 3. how big will the cell be? It'll be big because it's getting smaller and smaller as it comes down. Yes? Now keep that thought in your mind. Fewer division, bigger cells. Okay? Good. Just keep that thought in your mind. Again, fewer divisions mean a bigger cell. That's why megaloblastic means immature cells. If you had a big cell in the bloodstream, you'd call it macrocytic. So megaloblastic anemia, okay? Because you have these blasts or immature cells in the bloodstream. Again, megaloblastic anemia is an example of a macrocytic or a large cell in the bloodstream. Now, why is this the case? Because of these two vitamins. Again, there's the vitamins, folate. Why would somebody have less folate? Because of inadequate intake. Again, older people will have this problem. Or increased need. Now that would be pregnant women, lactating women would have an increased need. Or convalescent patients, people who have spent a long time in the hospital and they're kind of getting their life back to normal again, so you need increased need. Impaired absorption. So if this thing is absorbed, folate is absorbed in the duodenum and the ileum, and if the ileum is under constant inflammation with irritable bowel disease, that means they're not absorbing the folate. All right? Impaired absorption, impaired because of drug use. So you will prescribe anti-cancer drugs to people who have obviously malignancies. So like methotrexate. And that inhibits folate synthesis. That decreases the rate of division of the cancer, and hopefully you can help the patient out. So now you've got that problem. What about B12? B12, same kind of thing. Decreased intake because of poor diets. Increased need, again, pregnancy and lactation. Impaired absorption, okay, because you might not have enough of something called intrinsic factor. Parietal cells in the gastric mucosa in the stomach. There are two main cells parietal and chief cells. Parietal will make acid and intrinsic factor, it's a protein. Chief cells will make hepsinogen. Now, what's the job of intrinsic factor? It attaches to vitamin B12 in the stomach, and it kind of brings it along towards the ileum. The ileum is the last bit of the small intestine. And in the ileum, you have the receptor for it to enter the bloodstream. So it's almost like protecting the B12. So if you don't have the intrinsic factor, you will not have the B12. Okay. So those are the reasons you could have this deficiency of these two B vitamins. Now again, why do you need B12? You need B12 to make this fancy thing called 5-methyl tetrahydrofolate. And why do you need the tetrahydrofolate or the folic acid? Is to transfer methyl groups, 1-carbon methyl groups, okay, from one molecule to another, so you can make the DNA nucleotide called thymine. Now, you know DNA is made up of 4 basic nucleotides: thymine, adenine, cytosine, and guanine. Okay? So you need to make thymine. Or sometimes you need to transfer the methyl group so that you can turn it, into an amino acid of a different kind. Okay. So now we need folate and we need B12. What happens if you do not have enough of it? Now, before I come to that, just nutrition, where these things are found. Please, you don't have to learn all the numbers. I will never ask you what a normal absorption of folate is. All right? Again, B12, mainly in animal food. Cooking doesn't seem to affect it too much, so it's not destroyed or anything. Okay? We need about 1 to 2 micrograms a day. Our body has stores of vitamin B12 for almost 2 to 4 years, if you want, except for pregnant women, lactating women, older people, and so on and so forth. Okay? Where is it absorbed? It's absorbed in the ileum, the B12 obviously, but it must be attached to this thing called intrinsic factor. Look at the same thing for folate. Again, we require approximately 100 to 150 micrograms per day. We have about 4 months worth of it in our body anyway. Again, except for a newly pregnant woman, because you must give them folate. Why? Why? Why you must give pregnant women folate? Huh? Affect the who? The condition is called spina bifida. Okay? The effect is on the embryo. You will have neural tube defects. That's what you're talking about. Okay? When the embryo in the 3rd week forms a head and a caudal region, you then get a primitive streak that comes in, and you now start forming the vertebral column. For that, you absolutely need folic acid. Okay? Dr. Paul will talk to you about that. So, without folic acid, you end up having more neural tube defects. Yes? For what? Dr. Paul will tell you that. Okay? To diminish neural tube defects. Okay, so, again, this is like nutrition. Let's come back to physiology here. But before we come back to physiology, organic chemistry, please do not learn. Do not learn. Okay? B12 looks like that. That huge thing that almost looks like a spacecraft in space. Folate looks like the one on the top here. If you put 4 hydrogens on them, I circle the hydrogens, you will have tetrahydrofolate. If you take the hydrogen away from the nitrogen at the bottom and put a methyl, it's now called 5-methyl tetrahydrofolate. Why 5-methyl tetrahydrofolate? Because it is in that form that it kind of goes around the body. It doesn't go around the body in folic acid form or tetrahydrofolate. It's transported in the body in the form of 5-methyl tetrahydrofolate. It's attached to albumin. Okay. But do not learn. So now that you know that structure, let's just review replication. So, excuse me. You've got a double-stranded DNA, that's the parent strand. Can you see the parent strand? Yes? You've got the double-stranded DNA, the 2 purple strands. It's going to replicate, so the certain part at the replication origin, it opens up and helicase comes in. Can you see helicase? Yes? Helicase comes in, breaks the hydrogen bonds between the nitrogen bases and separates the strand. So you've got 1 strand on the top and 1 strand at the bottom. What then happens? Now you've got the template strand at the top. So on that strand, if that is the purple line, sticking out of it is a nitrogen base. So if it is C, you will get a nucleotide. Which nucleotide will come along? G will come along and base pair with it. Then the DNA polymerase, which is now here, working its way down, will come along and attach that G to the one that was before it, whatever that was. And now you're making the double strand as you're going along. Are we okay so far? Yes? And you have a leading strand and a lagging strand. You know, the molecular medicine people will tell you what's the difference between those. So if I magnify that a little bit, this is where the helicase, oh come on, This is where the helicase created the template strand. Can you see the template strand? So you've got an A, C, C, T, C, A, T, A. Can you see that? And the DNA polymerase has attached up to this point. Now you've got a C here, you've got a G that came in, a D stands for deoxy, G guanine, T tri, and P phosphate. It comes in, it base pairs, DNA polymerase will come along and it will cut the bond here and attach it there, and notice it has done it here. Are we okay so far? Yes, no? Good. And it will keep doing this as it goes along. So if I had an A here, what should come in next? A T. Are we okay with that? Good. Now I want you to look at something. So what did I need for A? I needed thymidine. Or thymine, you call it thymine. Yes? Okay. Now, come back. So I absorb folate, there's my folate, I make it into 5-methyl tetrahydrofolate, I attach it to albumin, and it goes around in plasma. When it's needed, it goes through the plasma membrane into the cell. No transporter here, it's fine, it's okay. It comes into the cell, and it gets converted into tetrahydrofolate. So from 5-methyl to tetrahydrofolate. And to do this conversion from 5-methyl to tetrahydrofolate, I need B12. Just live with me for a minute, okay? I need B12. When I have B12, B12 takes this methyl group, puts it onto a molecule called homocysteine, and turns it into an amino acid called methionine. Are we okay so far? Then what do we do with the tetrahydrofolate? We then convert it into methylene tetrahydrofolate or 5,10-methylene tetrahydrofolate. For that, we require serine, which becomes glycine. Now, why do we need our methylene tetrahydrofolate? Because that will transfer a methyl group to uridine. Now, where do we have uridine? What is uridine? What is U? It's found in RNA. So if you were making RNA, every time you had an A in the DNA, you put a U. Yes? When you put a methyl group onto U, it becomes thymine. A methyl group on U becomes thymine. And that's what this is telling you. So there's the methyl group, it's transferred onto U, becomes thymine. Thymine becomes obviously deoxythymine triphosphate, and it's now used in DNA synthesis. So let's go back. So this is replication, yes? I got an A. So I should have a what here? A thymine triphosphate. Okay? Now, come back. Oops. Come back. How do I make the thymine? I convert uracil, or uridine if you want, into thymine. How do I do that? I use this guy, which becomes dihydrotetrafolate, which then becomes tetrahydrofolate again, and now it can be, sent around as many times as it needs to be used. There's a question for you. What happens if you do not have B12? You cannot convert this to tetrahydrofolate. In which case, will you make thymine? No. What happens if you do not have enough folate? Then obviously you cannot convert it to this, and you cannot have this transfer taking place here. U to T. Will you have thymine? No. So, no folate, no B12, insufficient thymine. Are we okay so far? Let's look at the consequence of this now. Alright? So, you can look at all the reactions. Alright? Thymine, that you absolutely need on the top. How does a cell keep the little bit of extra tetrahydrofolate that it has? It attaches it to glutamate, an amino acid, and it kind of keeps it inside the cell. Okay, so take this one step further now. When you have folate and B12 deficiency, you will not make thymine. Are we okay with that? Yes? If you do not have enough thymine, now you're going through replication. Imagine this. You got a cell, DNA replicates, it needs to divide. Yes? It opens up its DNA, it's waiting for a thymine. Thymine doesn't come in. Who comes in? Yeah? Uracil comes in. Uracil comes in. So, in the DNA, uracil comes in. Uracil comes in, the DNA polymerase will attach it, fine, it'll go on. What comes behind the DNA polymerase? There's an enzyme that comes behind uracil, behind the DNA polymerase. Do you still remember? The DNA proofreading enzyme, the one that looks for errors. It's immediately behind the polymerase. So it comes along and it looks at this thing and it says, A, there should be a T here, but there is a U here. What does it do? It chops it off. It throws out the uracil. And the minute it throws out the uracil, it's created a space. What is it doing? It's waiting for a T. But there's no T coming. So what does it do? It just keeps going. Alright? So now you've got these breaks in the DNA where the thymines have been taken out. So you have DNA breaks and the cell might stop. So if that was at level 4, the cell might stop at that level. Will that be a bigger cell or a smaller cell? Bigger cell. Okay? So you got megaloblastic anemia because you stop the replication and the division from that moving forward. And that's what I'm telling you here. Okay? Now, thymine is not available, uridine comes in. DNA repair will remove the uridine, but without thymine, the repair will be unsuccessful. The DNA repair will leave spaces in the DNA, and if you've got both strands affected, you might even have double-stranded breaks, resulting in fragmentation of DNA. What's the effect of that? The fragmented DNA now, obviously, will be non-functional. It could actually stop. The DNA replication would stop. Cell division might even stop at a larger cell, okay, resulting in the cell dying and decreasing the number of remember the stem cell, the progenitor cells? You can decrease those as well. The cells that do survive, that go down through the division, will tend to be ineffective and therefore will be larger than normal. Okay? So together with increased apoptosis, cell death, and loss of progenitor and precursor cells, you end up having larger than normal cells. Okay? And therefore you end up with megaloblastic anemia. What does it look like in a patient? Well, there's an older woman here, and you can see the yellow coloration to her skin and her eyes. That's because too many cells are dying. She's producing a breakdown product, a hemoglobin, called bilirubin. Okay? Now, when hemoglobin is broken down, it's turned into bilirubin and another thing called biliverdin that's sent to the liver, and generally it is turned into bile salts, which assists fat digestion. In this woman, she's producing so much of bilirubin that it's ending up in the blood. From the liver, it's ending up in the blood, and therefore she's having this yellowish tinge to her skin. If you look at her tongue, it has this very strong pink kind of thing because the epithelium is lost. There is no epithelium. It generally should divide very rapidly and fill up that area, but she's not doing that. Again, why? No thymine, no DNA, no cell. Okay? And that is what we call glossitis. So lack of B12, impaired DNA synthesis, results in megaloblastic anemia. Okay? And again, you can have typical anemia kind of symptoms: fatigue, weakness, shortness of breath. Okay? This could also be because of problems with the GI tract, the alimentary canal. Okay? And again, loss of the epithelium in the GI tract because of constant infection of, say, the stomach. You know, somebody who has ulcers or gastritis. Okay? Nausea and constipation can cause these kinds of things. What will the cells look like? They will be hypersegmented because the DNA is broken up into pieces and they couldn't go down, and they will be larger. That's why you have these large oval-shaped cells that have lost their nuclei, but they stopped at a division far earlier, if you want. Okay? Neutrophils will be hypersegmented with more than, should be around 3 to 5 lobes, you know, and here you have quite a few. Because the patient has anemia, the bone marrow keeps trying to make normal red blood cells, therefore the bone marrow will become hypercellular. Lots and lots of cells kind of dividing. Okay? The serum will produce lots and lots of bilirubin, and again, you've got that yellowish tinge to the skin, to the eyes, and so on and so forth. B12. How is it absorbed? Again, you need intrinsic factor to attach to the B12. It kind of brings it along until the ileum, and then you have a receptor for it in the ileum to be absorbed into the bloodstream. Okay? Again, why will you have deficiencies? It could be intestinal or malabsorption. Malabsorption as in gastric issues, all right, or congenital lack of intrinsic factor. That could be it as well. Intestinal problems, and this would be anything from repeated infections of the intestine, too much bacterial growth in the large intestine, which now comes into the ileum, chronic infections, ileoresection or celiac disease, and so on and so forth. Okay? How do you absorb folate? Again, folate is generally absorbed in the duodenum and the jejunum, the first part of the small intestine. And who will have nutritional deficiencies? Generally people who are old age, institutionalized, you know, poverty is another problem, famine, and needless to say, physiological need would be pregnancy, lactation, okay, for obviously a woman who's going to give birth. Pathological conditions, these are abnormal conditions, obviously hemolytic anemia, malignancies, carcinoma will then decrease because you're treating them with drugs that inhibit DNA replication and synthesis and so on and so forth. Some drugs can interfere with tetrahydrofolate, especially drugs that are given to people who have epilepsy, anticonvulsants. So you have to be careful about that as well. Okay? I think that, come back to my friend. Again, 23-year-old. Why is age important in this one? Because these autoimmune or immunological diseases, because of gluten and so on, generally is at late teen, beginning 20s. That's how it is. That's why the age is important. Again, bowel resection, in other words, if this is B12, you probably have parts of the ileum taken out, okay? Because this young lady had problems with Crohn's disease or inflammatory disease because of gluten. Again, she has fatigue and dyspnea. What's dyspnea? Shortness of breath. Again, classic symptom of anemia. She is pale. Again, we know that. She has an unsteady gait. The reason she has an unsteady gait is because she's building up too much of homocysteine. What is homocysteine? Huh? She's building up too much of? Alright? No B12. She builds up too much of homocysteine, and that generally affects the neuromuscular system. And that's why she has that tentative gait kind of thing. Alright? Again, lab results reveal hemoglobin 10, very low, with a mean corpuscular volume of 120, very high. That means the division of the cells has stopped earlier on. So larger cells, okay, therefore it's a macrocytic, either B12 or folate or both anemia. Okay? In this case, it's probably a B12 because she has had small bowel resections. In other words, the ileum has been surgically removed because of the inflammation she's had. Okay? And that's it.